It's a pleasure to be here. Honorable Union Minister for Jal Shakti, Gajendra Singh Shekhawat, Minister of State Home Affairs, Shri Nityanand, Secretary of Ministry of Power, Mr. Alok Kumar. It's a pleasure to be here because what is a hospital that stands a flood or an earthquake without power, or if the roads do not allow the health staff or its patients to reach it. My first slide, please. Maybe. Well, I thank the audience because this is a Saturday morning and all of you are here discussing disaster risk reduction. I think at a timely, opportune time because the country is in huge investments for primary health care, huge investments for water, huge investments for power. But those need to be protected from natural hazards, events from natural hazards with regular return, like monsoons, floods, as well as the big ones, like what we have experienced in the past 3 years, now going 4, of a pandemic, which has stopped our lives. Should I just go there then? Thank you very much. Okay, a quick outline of my presentation is that it's an overview of health systems concepts, context of hazards, drivers, and events. We have to think in a more interrelated manner. Approaches. It's very important for us to have risk and vulnerability assessments. And I'll go through that a bit. What are health infrastructure assessments? Health systems capacities. It's not enough that the structure is there. How will it function? Capacities of other sectors that we have just talked about. A focus on health infrastructure was asked of me, and a focus on natural disasters rather than just epidemics and pandemics. And I'm putting a bit of an outline of approach for India. So, what is a health system? Consists of all organization, people, actions, where the primary intent is to promote and maintain health. So I would say that even the water sector is part of the health system. There is no safe water, we will have diseases. It comes at central, subnational, at community level, through a primary healthcare approach. And we have so many stakeholders. There's the state, government organizations, as in India, a huge public health system that is decentralized. As we all know, health is a state subject. Health service providers, private and public, not-for-profit providers as well, unions, other professional associations, and the citizen itself. People demand for health. What are their demands? And it's voiced through different ways. In India, there is a very powerful structure of the Panchayati Raj, which maybe is a huge ministry that we should be working with, and we've started to work with. A quick one here is that the health system framework, this used to be building blocks, etc., but we have to think about it in a more dynamic way. Service delivery, what are the services that Health and Wellness Center delivers? What about a PHC, a district hospital? How does that all connect in terms of referral? Who are the people who are trained to be able to deliver those services? Information. How are these cases recorded? How do we do surveillance? for example, for certain diseases or unusual events. Medical products, of course, vaccines, and again, India is a powerhouse here. It is the pharmacy of the world. 70% of all the vaccines in the world are actually produced in India. Financing. How is it financed? Again, in most recent years, we all know about Ayushman Bharat. It's all and leadership and governance. So it's all about bringing access, coverage, quality, and safety through in all these areas. Now, the issue is it should not be disrupted when there is an emergency, not when there is a flood, not when there is a cyclone or an earthquake or an epidemic of diseases, because every huge pandemic began with a small number of cases clustered. Now, all of these are tied through a governance and leadership mechanism. With that aside, what the health system is and what it consists of, our real world is full of different types of disasters. There are different hazards, and they cause events. Natural, geophysical, climatological. Well, I think in India it's only a volcano that's not present. Tsunamis, biological. It could be viruses. It could be pandemic diseases. It could be a cyclone. So some of those do a regular return because they're seasonal. With climate change, you've also seen that some of them come with more intensity, but less rare. Human-induced, it might be food insecurity, which causes migrations. It might be conflicts. All over the world we have this. Technological, industrial mishaps. As a country is actually industrializing, we may have this. It's called technological disasters. A chemical spill, how do you manage that? This, even transport accidents. It may be small, little by little, but when you look at numbers, it's a huge thing that can be prevented. So drivers are unplanned urbanization. We just heard from the infrastructure on roads, population movement, economic conflict, climate. So they all come together, and sometimes it comes to a place, a locality that is a perfect storm. What we need is a paradigm shift. We have to really think differently. It's not about a response or preparedness, but how to prevent. It's not event-based, it's risk-based. How do we assess the risk in a certain state, district, block, or a village? Reactive versus proactive. You can only be reacting well and responding well if you knew right away at the outset. Single hazard versus all hazards. Hazard focus, vulnerability and capacity focus. From a single agency, we need to be working together. I think the pandemic finally showed us what that meant. Individual responsibility versus shared responsibility of the health sector. So before, it's always it's increasing cases, it's an epidemic, it's just health. No, I think it's the co-responsibility of many sectors. And that's why the panel is here today. I'm very happy to be here. Response focus versus risk management focus. How do we manage risks? If we know that one state or area is in a fault line and high probability of a huge seismic event or an earthquake, then what we should look at is how resilient infrastructure is to earthquakes. And a plan around that, a multi-sectoral plan, not just a health plan. Planning for communities, but planning with communities. And building capabilities versus building capacities alone. If all the sectors are prepared and they have managed to set up, let's say, hospitals that are resilient to the hazards that are there, so are the roads, so is the power, so is the water, then it's a capability versus just a capacity. Because all sectors already know what to do and have prevented the emergency from becoming a disaster. We cannot prevent events, but the small emergency that's managed will not turn into a disaster if we move this way. So with all of those, we can probably achieve health security, universal health coverage. And with universal health coverage, conversely, you also decrease the vulnerability of the population. If the area that's flooded, everyone is vaccinated for measles, I am confident that there will be no measles outbreak. So conversely, that also happens. What's important is we have risk and vulnerability assessments. I'm proposing a bit of some work that we've done in 2018, where we overlay all the different hazards by geographic location during my work in the region. So what are the natural hazards present? What are the human-generated hazards present? What are the epidemic and pandemic diseases that may, endemic diseases with epidemic and pandemic potential? And where are they? I think that's the question. And where do they interact? It has to be overlay of certain data, so we have a dynamic analysis. Assess capacities using available benchmarks. I think many things have already been written. What is a safe hospital? What is a safe school, for example? And I think you can assess your capacities around that. The international health regulations also have set certain benchmarks for us to be ready for any epidemic. Here is a map. So this is the region. We looked at 5 types of natural disasters using just available data, the informed index. We looked at a few diseases with epidemic potential: Japanese encephalitis, Zika, back then that was the issue, MERS, which could have been another issue, in cholera. And then look at how capacities are measured in the health sector through IHR, core capacities, through the UHC index with WHO and the World Bank also putting an index around it, and another tool that we have developed for the region. So somewhere the truth is in the middle in that web chart, what our capacities are for events like this. Now, it's an outline of an approach, a proposition. Use existing information. You don't have to collect data all over again. Overlay assessments and map them. Overlay mapping of health facilities there. And then do a dynamic analysis that will inform design and function of health infrastructure network. Primary healthcare centers, where should they be? What kind of design should you have? District hospitals, blood banks, laboratories, expedite, it says. My reminder for time. And support infrastructure and develop plans informed by all of these together. It is a moment of opportunity for India because of the PM agreement. And this is where it can change. You can have central guidelines, state adaptation and analyses, develop coordinated plans through health and NDMA, prioritize high-risk districts, or focus on hazards that return regularly. Every year we have a monsoon season. Sometimes we always prepare for the big earthquake. We prepare for the big pandemic. But these events that happen yearly is something we need to prepare for. And you can input to the PM designs of such health facilities. There is a savings of a lot of funds if you design well rather than retrofit. There is only a bit of a cost, around 30% increase if you do a design that's very specific. Develop states, district DRR plans across sectors with a lens on health outcomes. Meaning, we should always think, okay, what would the health outcome be if we design a school like this, if we design an office building this way. Constant business improvement. So all these design of infrastructure need plans, and then all sectors need to actually do simulations. How do we measure resilience? There are a few, I won't go to the details, but there are a few pieces of work released last year of what a resilient health system may be and put some measurement in it. I guess I will end there in the interest of time. through an index and through another group discussing what are characteristics of resilience, because it's difficult to measure. Here is an old, very old, always updated guide from WHO of what a safe health facility is. And it has components of structural, non-structural, and functional. So, and sometimes, of course, the structure itself needs to be intact for an earthquake, redesigned for a flood, as you may see in other countries, or a cyclone. But it should function. So it could be simple things. An operating table, from my work in Nepal, is immovable. Because can you imagine if you wheel in the patient and there's an earthquake? So there are special straps for that and braces. Even laboratories, all the glassware is somehow secured. So very simple things and very big things. As well as a plan for every district for which you will always practice. More guidelines that can come together. The Sendai framework has done this. And lastly, a few takeaway messages. The time is now to invest in health, investment. It is an investment, not a cost. Invest in essential public health functions. And 1% additional allocation of GDP to primary health care will enable most countries to bridge current coverage gaps. Costs for improving emergency preparedness ranges from $1 to $5 per person per year. That's the gain if you invest in $1. Building health system resilience requires considering all hazards, a risk management approach, a method of assessment and measurement. We have to know what is the problem and address it quantitatively. Partnerships are essential. This is where our office is also working with different professional associations, CSOs. With CDRI, we're having a project for safe health facilities in Sikkim. We have done work with Geohazards International. They're also present in India and Seeds India on design of health facilities and retrofitting. Reducing drivers of risks, I call on the other sectors. If our air is polluted, health will be bad. And thanks to the Jajivan mission, really it's changing the health profile of basic diseases. The goal is to build capabilities, invest in institutionalizing a whole of government approach, which all of you are doing here, and linking development goals with health goals. There is no point in so many schools that have not been designed for the hazards in which they are located, or health facilities as well. I end there. Sorry for taking time.